Hello, everyone, and welcome to MedicAlert's live Healthy Hour. Today, we have some very special guests with us. We're really glad that you joined us. Many of you are returning. Others are new for the first time. Today, I want to introduce you to our host. My name is Melody Howard. I'm the Community Alliances Director at MedicAlert, and my co-host today is Vice President of Communications, Julie Hilton. Julie, are you on?
I am.
Great, thank you. So I'll share our agenda with you. Today, we will talk a little bit about MedicAlert. We'll meet our speakers, and then we'll spend the vast majority of our time on Q&A COVID-19 vaccines. We'll cover categories of current vaccines, special populations, vaccine rollout, and what comes next. And then at the very end, we'll share some resources for you. So the story about MedicAlert. MedicAlert was founded in 1956 by a physician in Turlock, California, who sought to protect his daughter when she had an allergy to a tetanus injection. So it started as a doctor's idea to protect his daughter, is now a globally recognized symbol for medical emergencies. What makes MedicAlert different? MedicAlert, we have a 24/7 emergency response team that's standing by to relay critical health information to emergency responders and our members' moments of need. We maintain an emergency health profile for our members, and we are the only nonprofit organization in the medical ID space. And our mission is to save and protect lives by sharing vital information in our members' moments of need. So how the service works, it starts out with your custom engraved medical ID. It has a 24/7 emergency response phone number engraved on the back, as well as your most critical medical information. In an emergency, first responders call MedicAlert, and we relay any additional information. And that information you can maintain online on your own personal health record. We do provide information right away in an emergency to help speed up your treatment and care. Julie, I will pass it over to you to introduce our speakers today.
Great. Thank you so much, Melody. One thing I did want to mention, which is very relevant to what we're talking about today, when we talk about that online health profile for MedicAlert, one of the things that you can store in there is your immunization history. So, given that you'll want to be able to tell people when and where you've had your COVID vaccine, want to make sure that everyone is making good use of that section in your online health profile with MedicAlert. So without further ado, I will introduce you to our very distinguished panel of speakers today. First, we have Dr. Nick Van Terheyden. Sorry, Nick. Dr. Nick is the CEO of Incremental Healthcare. He's an independent expert and leader in digital healthcare and sustainable innovation. He brings a distinctive blend of medical practice and business strategy, both national and international, to the realm of healthcare technology. A graduate of the Royal Free Hospital School of Medicine, University of London, he's a pioneering creator in the evolution of healthcare technology, who helped develop the first electronic health record in the early 1990s. His rare combination of patience, creativity, skill, and intrinsic business ethics has led him to a diverse career in healthcare with some of the most prestigious hospitals, consulting firms, and technology companies. We also have with us today Dr. Louise Saldana. Dr. Saldana is an accomplished clinician and physician, digital executive, and leader who served for several years as Chief Medical Informatics Officer for Texas Health Resources. He's nationally recognized and active in initiatives to develop tools to improve patient care quality and safety through health information technology and clinical decision support. Dr. Saldana also co-authored the current edition of the HIMSS Guidebook, Improving Outcomes with Clinical Decision Support. He's an emergency physician who practiced in the ED for 30 years and is a fellow of the American College of Emergency Physicians. Fred Goldstein is president of Accountable Health LLC, a healthcare consulting firm, and an instructor at the John D. Bower School of Population Health. He has over 30 years of experience in population health, disease management, HMO, and hospital operations. Fred founded a disease management company that provided services to employer groups in 10 state Medicare programs, operated a Medicare commercial HMO that was ranked the highest quality Medicaid health plan in Florida, and developed an award-winning mobile health app. He's worked with employers, health systems, and vendors to develop population health programs and services. He was directly responsible for the inclusion of the Medicare, annual wellness visit in the Affordable Care Act. Thank you for that, Fred. He's also co-founder and lead host of Pop Health Week, a weekly podcast. We are delighted, gentlemen, to have all of you with us. Thank you so much for joining today. We had, before I hand it back to you, I'll just say that we had a tremendous number of questions submitted for this session. This is clearly a hot topic with a lot of people. We apologize in advance that we won't be able to cover every question that was submitted, but we're going to try to get to as many as we can today. So I will hand it back over to Melody to take us through the questions.
Great. Thank you, Julie. So our first category is on current vaccines. So our first question that we have a number of people who submitted, including Darren, for the vaccines that have been approved so far, how do they work and what is their efficacy?
Well, why don't I kick off first? I know we're going to play tag team on some of this, and I know my colleagues will chip in as well. Let's talk in sort of basic terms. What do vaccines do? They induce an immune response in our bodies, and they do so without introducing the virus that causes the disease. Although that's not entirely true, there are different mechanisms by which we can create vaccine candidates. And some of them do actually use viruses, but not typically the virus that causes the disease. In the case of COVID-19, there's a number of variations on a theme. There's everything from using another virus that has the spike proteins that many people might be familiar with. You see in the picture that I think almost everybody on this planet has now seen of the COVID virus. And that spike protein is incorporated into some mechanism that is introduced to our bodies, and then our body reacts to that, produces the immune response, so that if you're then exposed to the COVID-19 vaccine virus, you will then, your body will respond and prevent you from getting the infection. So your body fights that infection. Why don't I let Louise answer the question about efficacy?
Yeah, and I will say that it asks about which ones have been approved so far. So far here in the United States, there are two that are approved that probably most people are very familiar with, and both of them use the messenger RNA delivery system, which is basically copies of the recipe for actually making the antigen, a component of the virus, and those are kind of used as kind of the delivery mechanism. It's like they're knocking at the door. So we have two of those, and one is Pfizer and one is Moderna, and both of those have, based on their phase 3 studies, showed in excess of 90% on the efficacy rate, and so very much more efficacious than was anticipated. The actual kind of bar they had in Operation Warp Speed when they did this was a 50% efficacy rate, but these farces surpassed that, and so something that we're very pleased with. There are two other vaccines that are kind of in the pipeline. One, the Astrazeneca vaccine, which actually has been approved and being used in the UK and other countries, which, as opposed to the Moderna and Pfizer, are one-shot vaccines, and but those use a different delivery mechanism, which is the adenovirus, which is a virus that typically causes like colds and things like that. So an attenuated part of that virus is used to deliver kind of that same recipe that we have for the others, and its efficacy rate, I don't remember an exact number, Nick, maybe you have, but it's right up there, about 90%, if I recall correctly, and they're, and I'll let you weigh in on that also, Nick, because you probably have some knowledge.
62 to 90% efficacy. Yeah,
and we don't. The reason we don't have the final numbers here is the phase 3 is not out or completed yet, and we don't have the data to give that. But I think what Nick gave as range is probably what we will see, and we'll probably see it approved in the near future within probably the next month or so. The other vaccine that's out there, the other candidate is the J&J or Johnson & Johnson vaccine, which also uses the adenovirus. And we don't have data on that. They actually are doing a phase 3 with one injection and 2 injections. So we'll have to see what the numbers come on that as well. So that's kind of the current state of the vaccine market.
Gentlemen, one question that came up several times in the initial questions around the mRNA vaccines, the Moderna and Pfizer vaccines, is do they contain the virus themselves? I believe you're on mute, Nick.
Wow, that's the first time, but anyway. So I'll be categoric about that. They do not contain the vaccine. They contain small pieces. So imagine a Lego building of Darth Vader as the virus. What you have is maybe his helmet or a piece of him that is incorporated into the vaccine that's delivered, and your immune response responds to that piece of it. So it's not the full virus, and it can't cause the disease.
Thank you for clarifying that. Melody, I think we can go to the next question.
Great. So the next question submitted by Alyssa. What's the difference between the Pfizer and the Moderna vaccines, and is one better than the other for certain populations?
There are some differences, but they use the same principle. So their method of action, as Louise said, is messenger RNA, which is part of the construct of the virus. And they both have the same principle of being introduced in the body in a special carrier particle. It's a fatty particle so that it gets taken in and doesn't get consumed. Much like when you eat something, your body just consumes it. It doesn't actually, you can't eat a vaccine, for example. So we struggle a little bit with that with some of these vaccines. As far as better than the other, they're actually very similar in terms of efficacy. They're both north of 90%. One is slightly more than the other. Probably the biggest difference is the storage requirements and transportation requirements that require super cold storage. And that's actually going to determine much of the use case and the distribution, because if you have to have this super cold storage, it creates all sorts of logistical problems, and we'll use the virus that doesn't require the same super cold storage.
I think you meant the vaccine, Nick.
I'm sorry?
I think you meant to say the vaccine, not the virus that doesn't.
Yes, I did. I'm sorry. They both begin with V. It's very challenging to get this. Same as my name as well. For places that are very remote, we will typically use the ones that don't require. For large city conurbations where you've got cold storage capabilities and you've got many people, there's also different distribution sizes. In the case of the Moderna vaccine, that comes in units of 100. The Pfizer comes in units almost 1,000. So you've got to have 1,000 people. So that will drive it more than the efficacy.
Yeah, I would agree with that. It's really more of a logistical supply issue. And if somebody was concerned, I wouldn't hold out for one versus the other. If that's kind of part of the question, I would be very comfortable taking either of the vaccines. And so I don't think there's a really big difference there.
Great.
And that was a lot of concern with a number of the questions that came through, is one better than the other. So thank you so much for that answer. Our next question submitted by Mrna. What are the side effects of mRNA vaccines?
Well, I'll kick off this one, Nick, if you can kind of weigh in and clean up or pick up after me and things of what I may have missed. Pretty much any of the vaccines have very similar side effects. As Nick kind of elegantly explained, these vaccines are intended to stimulate the immune response in your body. And so that immune response sets off what, some people recognize from even say flu shots and things as kind of a flu-like illness. So probably by far the most common is side soreness, so a sore arm. Fatigue is very common. Some even have a low-grade fever, body aches, those kind of things. Some folks have GI symptoms, but I would tell you that most all of it, it's a pretty broad spectrum of side effects, most of which are mild. There are some people that have a much more robust kind of response or reaction for whatever reason. We don't know who's going to be one of those and who's not. These aren't indications of an allergic reaction or signs you've gotten the virus, as Nick kind of explained, but really more the signs that your body is working and responding to the vaccine. If you have very, very mild symptoms, that still doesn't mean your body isn't responding very well. It could be responding very well. Just the kind of the state your body is in at that time in terms of the response or your immune response and the impact of your immune response on your body. The number of true allergic or anaphylactic reactions is very, very low. It's certainly less than 1 in 100 from the number of doses that have been given of the vaccines. And I don't know if I covered that, Nick, if anything I missed on that.
Yeah, I would say the summary is if you've had a flu vaccination, similar kind of side effects, although there are some, additional ones that are slightly different. It's, it can be mild or moderate. I've seen all with people that have had it to date, but it doesn't tend to last. It's typically a day at most.
Could you guys just sort of touch on the first versus second shot and the incidents we've seen with that, just so people recognize that?
Yeah, good point, Fred. So there is an increase in the response, which you would expect if you think about this. So your body's mounting a response. You give the first dose. The body says, "Hey, this is the virus. I need to react to it," and develops the reaction system. But you don't get that feeling of, as much of the the feeling of disease at the time that you're having that first dose. When you induce the second immune response, your body's already prepped, and that's it actually saying, "Hey, I'm ready for this, I'm going to fight it," and that's your body reacting. So people do seem to have a slightly increased response in the second dose. Not all people, and some people have no response at all to the vaccination when they receive it.
Helpful to know. Thank you.
So our next question, we had many folks ask these different questions. Once I'm vaccinated, how long before it takes effect? How long am I immune? Can I still get or spread COVID? Do I still need to wear a mask and social distance?
Okay, I'll try and knock these off. How long it takes effect? It's certainly a couple of weeks is our expectation. You do develop some immunity, but in terms of the levels of immunity, they don't develop as much until you've received the second dose. Although, as Louise pointed out, we're now testing to see if we can issue one dose. Then there is some level of immune response, but it's not quite as efficacious. We don't know the answer to question number 2 for certain. We believe that it's certainly months, at least some period of several months. It could be much longer than that. And until we have more experience than we've got currently, which is, as of today, I would say we're almost at 12 months of any kind of experience with this particular virus. But we'll continue to learn and obviously monitor that. Hopefully you'll have an enduring response. On that point, I did see a quick question and I'll pick it off. I've had COVID. I don't need to get the vaccination. I would tell you if I'd had COVID, I would still get the vaccination because you might not have mounted a good immune response. You might have had a subclinical version of it. And we believe that giving you the vaccination will actually improve your resistance should you be exposed again. So it actually is something you would consider. Can you still get it or spread it? Absolutely. As you heard, 90 to 95% efficacy. That means that at least 5 or 10% of the people don't get or might not have protection, so you could still get the disease. And we're not sure. Again, data is still to be understood, and we've still to gather the data. You could be resistant to it, but you might get the infection and still be able to spread it, which is why you do need to wear a mask and continue to mitigate until such time as we suppress the virus and the pandemic sufficiently across the whole population that we can start to relax on some of these issues. Anything I missed, Louise?
No, I don't think so at all. I do want to remind folks that part of why I think there's unknowns in this set of questions is we got to remember how quickly these vaccines were developed. You were talking about under a year, and so to get to phase 3 studies. So I think given more time, they would have studied all these other questions possibly if they had kind of more the luxury of having more time. But they needed to get this out there, and so I think that's why they can't give you the final answer on some of these things. I think they will become clearer. On do I still need to wear a mask and social distance? The answer will be yes. How long will that be? I think until our public health specialists, our scientists tell us that we have reached herd immunity as a population. And we have to think about that. Is that in your locale? Is that nationally? Is that internationally? All of those are different questions. So does that mean I get to go travel if I've had this? Probably globally, that may not be, because the vaccine's got to get all around the world. So I would caution you to think. So certainly, I think wearing a mask and social distancing until we're told otherwise by our public health scientists, I think is the right thing to do to protect everybody.
One question I had here is if, and this may be something we don't know because it's still very new, is it similar to the flu vaccine in that I've had the flu vaccine, but I possibly could still get the flu, but just get a milder version of it? Is that similar? Does it work?
Yes, that is. There was actually kind of two different endpoints when they looked at in the phase 3. One of those is getting the disease, and number 2 is getting severe disease, meaning you were hospitalized, go intensive care units. They had very, kind of specific criteria for identifying those, and almost certainly it's got a highly protective effect of getting severe disease, which I think is something else that's comforting. I think it is. So that's a kind of another protection. If I get this, it's not going to be the severe version of the disease, but as much based on what we know at this point.
And given the challenges that many hospitals are having right now with capacity, the more people we can keep out of the hospital and with milder versions of the disease, the better off we'll all be.
Absolutely.
Flattening the curve, as we talked about earlier on in the.
I know. How did flattening the curve go away? People sort of did it for a while and then forgot about it.
Because the curve's pretty steep right now.
Yeah, that's true.
Our next question submitted by Jamie, Robin, and Yolanda. Will the current vaccines work for any new virus strains or mutations?
Yeah, I'll weigh in first and let Nick weigh in as well. Again, probably TBD. I think it has been tested or looked at with existing variants. So there's two different things. Yeah, it's the strain or variant is a combination of mutations. So mutations are kind of individual kind of errors or changes in the DNA or genetic structure of the virus, and the strain is just or variant is a combination of those things. And that happens these happen with all viruses as well, and that's something that's considered. Two things I think here are important. To the ones that we're currently seeing, there's no indication that they're not going to be efficacious at this point. They kind of have to probably say at this point. And then second, the other promising thing is if at any point there was some quote escape of some sort, the messenger RNA technology is such that it could easily or quite quickly be adapted to changing circumstances. But I would go under the fact or the working hypothesis that they will work for any new virus strains.
Yeah, if I could just add something here. If you go back to what Nick said earlier about Darth Vader being the Lego, and so let's say the mRNA virus does a piece of the head, the arm, the leg. They use multiple pieces to create the vaccine. So it would have to mutate at multiple places. And so it does allow, then they can figure out, oh, that one changed, as Louise said. And so you can think about it that way. There's been a change in a place and it might cause something, but these viruses just mutate naturally. And so it's not really a huge issue because they have a bunch of them, but over time they watch that. And as Louise said, they can develop something to then go after that one that is slightly different with a different helmet or a different arm and leg as they've matched it up.
I guess the way I've heard about the mRNA vaccines described is they're a messenger, right? When they are a messenger RNA, and they provide instructions, a set of instructions to your body on how to fight the virus. So that set of instructions can be tweaked fairly easily, I'm assuming.
It's why I picked the Lego model. Obviously, I'm a Star Wars fan. That's why I picked Darth Vader, but that's exactly right. And if you look at the history of that particular vaccine candidate, it was developed in the space of a week based on somebody publishing the virus genome sequence out of China. So, that's an extraordinary pace of progress, to Louise's point and Fred's point.
Which actually takes us right to our next question.
So the next question by Ursula and Teresa. These vaccines were developed so quickly. How do we know they're safe?
Well, I know there's a lot of concern out there. There are a number of things that I would say contribute to our understanding. And, as Louise pointed out, we're going to continue to learn, but they have done a truly astounding job. And point number one that's important to understand is that this was not just 12 months of development, but actually 10, 15, even more, 20 years of innovation that has come to the forefront. We were lucky in timing and also focus and international cooperation. The messenger RNA technology has been around, vaccination technology has been around for a long time, but we haven't managed to get it to work. But that all came together. They had actually resolved that problem some years ago. Our ability to assemble these things. And then actually one of the other things that helped us was the large number of cases and exposure to cases allowed us to run some substantial numbers of people. So we're talking 20-odd thousand of a proper controlled study. So that was a study where one arm of the study received no vaccination. They actually received an injection. It was a placebo. Nobody knew the person giving it, the person receiving it, and then an arm or a couple of other arms in terms of some of the trials that compared that. And the results were very, very compelling. And as Louise said, the side effects and reactions that we've seen occur, and they occur with any instance of this. There is nothing that is perfectly safe, but they occurred at a very, very small percentage or level. We have seen this reaction of anaphylaxis. So the current guidance is people that have any kind of anaphylactic reactions or challenges with responses, they should be cautious in approaching that and should absolutely receive clinical guidance from their physician provider to determine the appropriateness depending on their specific instance. I saw one track pass where somebody said they had a penicillin allergy. That may not be related. I'm not saying it is or it isn't, but there's a spectrum of all of this. And then the final thing I would say, I'm a physician. If somebody showed up at my door today and said, I'd like to give you the vaccine, any one of the three candidates that we have currently approved, I would take it in a heartbeat.
Yeah, I will just add that while these vaccines were developed rapidly, they did not skip steps. The steps were all there: phase 1, phase 2, and phase 3 studies. And as a matter of fact, it looked like early on the Astrazeneca was going to be maybe the first one on board, but they had some cases of a neurologic issue, and so they actually halted and took a look at it and evaluated more deeply before moving forward. So I think that shows that they did not trade speed for safety. I think they what they did was balance speed and safety here. They knew that this was something that had come in rapidly, and we needed to have a response that was just as rapid. And so I think from that standpoint, we should be very at least comfortable with the process and that no steps were skipped.
Great.
So our next question, submitted by Curtis and Meg, are there clinical trials that measure the efficacy of a single dose?
There may be some that are being done. Certainly, I think I don't know if we're talking about for the Pfizer and Moderna vaccine. Like I said, I think with the Astrazeneca and the J&J, there are studies looking at single shot. But for the Pfizer and the Moderna, they have looked at or are in the process of looking at two smaller doses. You can actually, and I'm not going to get into the science, but you can actually go back and look at the curves for each of these when it shows some effectiveness, and that's by looking at cases. And you definitely see some effectiveness after that first dose. But all of these were tested for the second dose, just for the reason Nick said. The first one is really just a priming dose, and that second dose is really supposed to really turn on the immune response. So I at this stage, I wouldn't want to see anybody take the shortcuts, and I know there was some discussion around this, but I think on those, the best recommendation is still to get both vaccines if possible, and so I would operate under that hypothesis right now.
Yeah, we had a number of people ask questions both before the event and in the chat. If I got my first dose, but for some reason, the second dose isn't available, I can't get it on the time frame that they originally prescribed. What's the impact of that?
Well, I think it's being tested under the schedule. Or schedule, forgive me, I forget which way to pronounce it these days, as per the trial. And obviously that's preferential. But if you fail to meet that precise target, the body's a pretty, responsive system. And if you get the appropriate second dose a little bit later, that's not the end of the world. We don't know exactly what that does. It might improve your immune response, or it might be slightly less, or it might just be the same. We don't know for sure because we haven't tested it. But all our experience with other multiple dose vaccinations is essentially the second dose, continues to push the body to really mount a solid immune response. I did see another question. I've heard this multiple times. I'll just pick it up because it's contextual to this. If you have Moderna, can you have the Pfizer second? That's really not the optimum, and we discourage that. I know the UK government issued guidelines that it said in an emergency. So if there was no other course of action and you were just out of all the doses for the first dose that you had, then you could do that with the same vaccine system, but it's not advised. And it's certainly not anything that we've tested and know for sure.
Got it.
Yeah, I would agree with that. And yeah, I think a few days on the schedule is not the big thing. As I said earlier, if you look at the curves, kind of from the science, we look at that, I don't think the exact timing of that second dose is important. The important thing is to get that second dose.
Got it. I think the next question Nick did touch on earlier in terms of if you've already had COVID, do you need the vaccine? I think the answer was yes. No, that's fine. Glad you talked about it. The other question is, when do you get it? If you've had COVID or if you currently have COVID, what's the timing? Is there any optimal timing to receive the vaccine?
I would, you don't want to be taking a vaccination whilst you're suffering from the disease. But at any point after that, I think, it's appropriate to do so. However, the one point I would make is that if you've had the disease, we pretty much view you as having immunity as a result of that, at least some level of immunity. So it would be better if you could wait so that those people that have zero immunity can access the limited supply of vaccines in the earlier stages. But beyond that, I think it's something that we would expect you to have in the subsequent weeks or months afterwards.
Yeah.
So our next question.
I'm sorry.
Next question, in special populations submitted by Lauren, Elise, and many others. Is the vaccine safe for women who are pregnant, breastfeeding, or plan to become pregnant, those with an autoimmune disease, or are immunosuppressed, or children?
Yeah, I'll kind of start. These are all categories that are kind of special circumstances that really should be discussed with their own physician on making the decisions, because they weren't specifically studied. But on the first one, pregnant, breastfeeding, or plan to become pregnant, what I'll tell you is that I know several physicians that fall into or have fallen into that category, and all took it as well. And the guidance, I think, from the most recent guidance from the American College of Obstetrics and Gynecology, ACOG, was that they would recommend it as well. But knowing the fact that they weren't studied, but they just based on what they know about vaccines, they had no reason for concern based on what they saw. But I think that's an individual decision. I think you need to talk with your OBGYN on that one. On the second two, the same way, I would tell you every individual circumstance of autoimmune disease and immunosuppression are very, very different. Those are huge spectrums of issues. And I would tell you the 80-20 rule, is most would say yes, get it. But again, because of what drugs you may be on, transplants, there's a lot of different things. Each of those need to be discussed individually with your physician clinician on making the decision. On children, they have the two candidates have not been approved for anybody below 16. Am I right, Nick? One may be 18 and one may be 16, but I don't want to be pinned down on that. But I think that's right. And so at this stage, they're moving very quickly on trials on those, and I think we're going to see data pretty quickly on those that'll have that data. So right now, children would not be in that first group that you'd want vaccinated.
And I'll add a little bit of color to that. The reason for that is that they're not part of the trial. So when they assembled that trial, they specifically exclude those populations because they tend to be, and put the one in the middle, the autoimmune, as Louise said, very special case, always excluded. And we strive to understand that in detail at an individual level. From a pregnancy standpoint, obviously we need to test it. And in fact, I'll tell you the good news. There was a number of individuals in the trials who became pregnant after they had received the second dose of the vaccines in that particular trial, and have been doing well so far. It's not a huge data set, because if they had become pregnant at any point prior to that, they would have been excluded and taken out of the trial from a precautionary basis. And the same is true with children. And Louise is right. I don't recall which one is 16, which one is 18. It's a testing issue, but we're working on that. We're continue to sort of advance the science.
So I'm assuming the priority was, we know that people that tend to be older and tend to have other pre-existing conditions are more at risk with this. So let's make sure that we address those needs first. And then right. Kids where we're not seeing, obviously there are kids that have gotten very ill and there have been fatalities, but not as many as in the older populations.
Correct.
Okay. This question, I'm sorry, Melody, keep stepping on you a little bit. If we had one question that was the winner of all of the questions that we were asked, this is the one that literally got asked dozens and dozens of times about anaphylactic reactions and allergies. And I think that part of that is because there've been some sort of highly publicized reactions What doesn't get publicized is the tens of thousands or millions of people that have the vaccine and don't have a reaction to it. But there's a lot of concern out there among our population that have anaphylactic or allergic reactions. So if you can talk to that a little bit more, I think that'd be helpful.
Yes, so Louise, I think, articulated this very well. It's something that we consider individually. It's not something that I would give any global guidance. I saw some very specific conditions and mentions. I wouldn't even deem to sort of address that. I would want to know the patient's history, the context, as he mentioned, drugs and so forth. I think in general, one of the things that we're doing, and this is part of the challenge of the distribution, is people are being vaccinated, but they're being observed specifically for a period of time, 15 minutes or so subsequently, to ensure that there is no reaction. And if there is, we know how to deal with it, and they're in the right place to be able to deal with it. So, and in the cases of people that are potentially at slightly elevated risk for a variety of reasons, there will be even more caution and an appropriate sort of coverage around that. This is true of anything that we introduce into bodies, and some people have reactions, but the experience with these vaccine candidates has been very rare.
Yeah, and I will also kind of add that the CDC is actually doing kind of a vaccine adverse event reporting system. So they actually are capturing the data on this. And this was from about 5 days ago, but they detected 21 cases of anaphylaxis after administration of almost 2 million doses of the Pfizer vaccine. And so that's 11 cases per million doses. So 1 million people get it, 11 people have an anaphylactic reaction, and 71% of those occur within 15 minutes. So it goes to the observation period that Nick said. If you have a history of anaphylaxis or allergic reaction, you should certainly, as Nick said, consult with your physician, allergist, etc.
So our next question is in the category of vaccine rollout, submitted by Jeff and Linda. How are vaccines being distributed? How are they different, or how are the different eligibility categories or phases being decided?
This is a complex, it's a topic, or maybe controversial. What I'll say is right now, not very well on how they're being distributed. And a big part of that is that there's not a federal response. The federal government is deferring to the states, so they're basically distributing vaccine to the states, and then letting the states do the prioritizing, distribution locally, and those type of things. Fred may have more information to kind of share on that. He's been watching this pretty closely.
I would add for each of the people attending to look at your local county public health department, because, for example, here I'm in Northeast Florida. Every single county is doing it differently. One of them has a sign up on the internet, one of them has a phone line, one of them is using Eventbrite, and I know there was also a question here about when do the pharmacies get it, and we're starting to see that depending on the counties and the states reaching out. For example, I know that here in this area, Publix is now going to be giving vaccines to people. So it's really important to look locally, because as Louise said, there is no one overall driving strategy at this point. And so it's very different depending on where you are in the country. My mother is in Northern California, and the public health department came into their community and is now vaccinating first those that were in a skilled nursing facility in that community, and then those that are elderly. So really locally, get your information, try to keep up with it, and use that to make your decisions, and try to get in as appropriate for yourself to get that vaccine.
At the end of the webinar, we'll provide a link to a website, and one of the resources in there is the vaccine distribution by state and links to each of the states. That's one of the challenges, is that they're wildly different depending on where you are, and you really need to focus on that. Some states have done an astoundingly good job, others have not, unfortunately.
And I saw one other question there about deciding on risk factors for Group 1D. And That's individuals that are over 80 or have 2 or more conditions. And there is a list on a CDC website of those conditions. And so it's important, obviously, to talk to your physician and figure out, do you have to tell the public health department that I have, diabetes and asthma or whatever it might be that makes you qualify for that, or how you would do it. But it'd be a good idea to try to investigate that a little bit and talk to your physician about it and see if it needs to be proven in some manner, or how you would end up getting on the appropriate 1D list for that. And again, the states are looking at that differently as well, or the communities themselves.
I think our next set of questions talk to those logistics a little bit. Like, how do I get, that's what the other, I think if we had a second question after the anaphylaxis question, it was like, how do I get on a list?
I think we're all asking that question, depending on where we are in that priority list. I know I am. And unfortunately, depending on where you live will determine much of that from a state and potentially local, as Fred outlined. I would encourage you to go to the state resources. In the case of my particular state, they have a text message system that updates and will alert you when they move to each of the categories once they've finished with 1A, and so forth. In other states, I know that they have a sign up that allows you to sign up now. They'll sequence you based on their categorization and then essentially call you up. But that's more the exception than the rule, unfortunately. And from the pre-existing conditions, as Fred highlighted, I think this is a bit of a patchwork. There's no sort of confirmation. We've certainly seen some instances of bad actors. I would sort of expect and encourage people to declare those pre-existing conditions so that they can be categorized appropriately and put into the appropriate sequencing, so that you get the vaccine at the earliest point relative to your risk. When it comes to choosing the vaccine, I would say that's given the paucity of availability, I would encourage you to take what you can get. I don't think we're in that circumstance at this point.
I would just
and I will add one thing on this, and because I think it does show a failure of, and I've worked and Nick's worked in health technology and things, that is ideally we should be able to have our health records give a priority, a risk score, something like that, would be so ideal, and have the priority kind of come out that way. So we'll take out some of the subjectivity and things like that. Certainly this shows a kind of a shortcoming of our current issues with the healthcare technology and the use of data at this stage. So I'll just kind of maybe throw in that kind of a editorial statement for both the promise and failure of technology to help us on these.
And just one more important point for the folks: they're going to get a second shot, so they need to know when they get the first one how they're scheduled for the second. So for example, in one county here, they're saying you need to come in at the exact same time 4 weeks from today. And that's all they tell you. Another one may send you a reminder, or you may get something. So please understand when you get the first one how your local community is handling that second one, and keep up with it so you can make sure you get back in for that, because they're using different methods.
So what comes next? This next question submitted by Donna. Are the COVID vaccines a one-time only thing, or will we need annual shots like the flu?
I think TBD, we don't know yet. Certainly all this with, the mutations and different variants that are out there will influence this. It's hard to know. I think that, best case scenario is no. Best case scenario is it'll be a one-time thing, and the virus may turn into something like a seasonal virus type of thing. The important thing I do want to point out, because maybe we haven't mentioned this, that's important on the immunity is it's not like T cells, B cells. This is we're talking about as scientists. This is kind of a multi-pronged approach to immunity, and some of that is going to persist and will give us some protection afterwards. If I was pressed, I would say it's probably only a one-time thing. because the virus, I think, will will have such a good hold on it that it will become maybe a seasonal type of thing. So you may have little incidents pop up here or there, like just what we've seen with like Ebola and throughout Africa, things like that, even though it's a very different virus. But I will say it kind of can get suppressed and go away for even a long time. So it's something that needs to be watched, but I would say TBD on that.
You know, one question that came up, again, pre-event and then again during the chat, is, you know, this is literally a national emergency. I think 4,320 people died in the US yesterday. Is there anything that can be done to speed up vaccine rollout?
Yes.
Yes. I think we all.
I guess the question is, will those things be done? We know that things could be done, but you know, do you see anything coming on the horizon that will improve the outcomes?
I try to steer clear of politics, but I think you know, some change and more centralized leadership. You know, to Louise's point, Fred's point, this patchwork approach has really sort of hurt us in the last mile. We do know how to do this stuff. We do things incredibly well. We've got systems that work and can distribute. There are challenges. We've certainly learned some things. I think we can get much better, and I think we will. And I'm hopeful that we will do so quickly, because that's what's important at this point. So I would say I'm hopeful about that. And I'm hopeful that the learning experience from the failures will allow us and inform some of that and make for a more centralized approach. You know, people on this call can probably tell that I don't hail from these shores. I come from the United Kingdom and the health system there, where, you know, it's one country. This has 51 countries with different counties and all of these, you know, competing interests. And in this particular instance, that's been, you know, something of a hindrance to some of our responses. And we need a little bit more of a centralized, coordinated approach. And I'm hopeful we'll get that.
Mm-hmm.
So next question submitted by Robert and Cheryl. Other vaccines in development, what else is in the pipeline? How are they different than the current vaccines? And when will they be approved and available?
Well, let me just give you a superficial answer to that. The last time I looked, there are 180 vaccine candidates. We are familiar, I think most people are familiar with the three main ones, the ones that are approved certainly in this country. And there are a number that are approved in other countries, but we have no data to know how effective they are. We're not sure what the trial date, so none of that is published. So in terms of published confidence in the information, it's limited to those three. There are a number of others, and there's probably of the order of about 7 major categories of techniques of development of vaccine candidates. And they're trying in all of those different frames. At some point, I suspect some of them will wither on the vine, because it will no longer be relevant, to Louise's point of, you know, diminishing requirement. But I think work continues unabated across all of those. The other problem is that they don't have as many people to now test, because everybody's going, you know, who's going to submit for a trial if they can get access to the vaccine? So it creates some of its own challenges in terms of sequencing and, you know, continuing to make progress. But, you know, that's good news, because if we don't need them, we don't want them.
Yeah, and I'll just add, I think I might have mentioned earlier, the two that are kind of next up are the Astrazeneca and the Johnson & Johnson vaccines. I would expect the Astrazeneca to be the next one approved, followed by the Johnson & Johnson, probably in the next, you know, month, 6 weeks, 2 month time frame, I think. And like Nick said, there's China, Russia has been rolling out vaccine out there as well, giving it to large numbers. So it'll be interesting to watch. Certainly in China, they get to huge numbers of people. So it'll be interesting to follow their data.
This is another question that isn't explicitly on the page, but is something that came up in the chat as well as pre-questions. No one's going to force me to take the vaccine, right? There's no requirement that I do so. Do I still benefit from other people getting vaccinated?
Yeah, so yes, that's true to the best of my understanding and knowledge. I don't think, there is a compulsion or a requirement. I understand, the limits and individual freedoms that this country holds dear. From a mandate standpoint, I think, obviously we're going to do everything that we can to encourage as much uptake, with confidence in the safety, obviously public, individuals taking of those vaccines. I know that this is a sensitive subject, but ultimately herd immunity only works if everybody, participates that can. There are some people I know on this call who will have immune suppression and reasons that they can't take just ordinary vaccines, forget the COVID-19, and that's well established, and they depend on that herd immunity. It always reminds me of the story I learned at school, where the whole country said, let's all jump up and down at the same time at midnight, 1 second past, and we'll make this big bang and everybody will notice. And what happened was everybody stood there and thought, well, I'm not going to jump because I want to experience it. Nobody jumped, and we never got any effect. It's the same with vaccines. We have to participate where we can. Obviously, we've got to take account of our own special circumstances, but mandates are not a good thing generally. It doesn't induce, positive experiences.
Right. I'll just make one comment here. The EEOC has stated that an employer can mandate the vaccine except for religious or potential other beliefs, but can mandate their employees take it. So there is some of that legally.
And that may be the case for travel. That could come up as travel.
Oh, sure.
I think we just saw that the U.S. is going to require tests for returning for international travelers. I think, proof of vaccine could also be something on that. And I want to say something about herd immunity, because I think this is one of the times, we don't want to get into talking about mandates, but where we really have to think about the greater good. We don't know a number. There's not a 75%. Who is the 75%? Does that include the kids? Because we're not even vaccinating kids. So we have to look at it. So I think the greater good thing is take it unless you have an absolutely important, critical reason not to take it. I understand vaccine hesitancy, but this is probably one of those cases, and I'll get up on my soapbox, where we all have to be in this together to get out of this together, right. Honestly. And so that's all I'll kind of how I'll leave that.
I think that's a perfect way to put it. Previous speakers have talked about it as, here's a path back to something approaching a normal life. And I think if anything, that's what everybody really wants. And this is something that is relatively low risk that we can all do together to get us to a place where 4,000 people aren't dying every day. So gentlemen, thank you so much. This has been so helpful. We had a million questions we didn't get to. So I may reserve the right to ask you to come back at some point and talk to us when there are further developments around this. I want to talk to you a couple things that we'll share with you. There is a really good collection of resources that these gentlemen have put together that includes, tracking COVID, how the vaccine's being distributed, what resources are out there for testing. And the section I really liked with is Mythbusters. There's a lot of misinformation going around, and I found that section really helpful. So I encourage you to check this out. Everybody that registered for the call will be sending an email as a follow-up that'll have this link in it. So we'll be able to send you right there. And then just go back 1 second, Melody, sorry. These gentlemen also do a weekly discussion on COVID and kind of what's going on in the market, how employees and health departments and everything are doing. I think you actually have one at 4 o'clock today.
Correct.
Okay. Information on how to access that is on this link in this page as well. So would encourage you to follow them and to participate if you're interested in further information on this topic. We also pulled together for you a couple of things, what the CDC had to say about the vaccines, as well as some very specific Q&As from the FDA on the Pfizer and Moderna vaccines. And we'll share more specific information on the other vaccines as they're approved for use. Lastly, I would also say that from a MedicAlert standpoint, knowing that many people that have MedicAlert have very specific chronic medical conditions, we've curated information from very trusted resources on what COVID means for you specifically, and other general resources around coronavirus, but trying to create a place that is a safe space for COVID information, similar to the gentleman's page that we talked about earlier. We've also done, I'm not sure what this is, number 14, I think, of these types of events, talking specifically around coronavirus and other subjects. So I really encourage you to check out the link. We'll provide this link in the email as well on some of our previous events. I've learned a lot through all of these, and if you enjoyed today, I think you'll enjoy some of these too. Going on to the next, in 2 weeks, we have coming up in partnership with the Epilepsy Foundation, a session on living with epilepsy. Brooke Gordon, who is the vice president of the board for Epilepsy Foundation, and herself, someone that lived with epilepsy, will be sharing her story and interesting things that are going on in the epilepsy treatment world. So we're very excited about that. That is live on our page, and you can register for that now. One last thing, I will say that if you enjoyed this and you'd like to support MedicAlert in bringing more of these types of events to you, we're a 501c3 nonprofit organization. All donations to MedicAlert are tax deductible. It supports that 24-hour response service, the education we provide to first responders, and providing memberships to people who need the safety of MedicAlert but aren't able to afford it. So if you'd like to contribute, we would be ever so grateful. So I'll say one more time.
The invitation, and sorry we couldn't get to all of the specifics, but hopefully we covered enough of the generalities and got into the detail. And we thank you for all your questions and thoughts. It's helpful to us to understand what's circulating in terms of knowledge, understanding what people are asking, so that we can be better at answering those questions and helping people understand.
Awesome. A replay of this event will be available tomorrow on the MedicAlert site. And again, we'll send that with the email. But gentlemen, thank you again. Very much appreciate your wisdom and up-to-date information on this really important subject. And we wish everyone a great afternoon. Thanks everyone for